Good morning, good afternoon, and good evening. I'm Dr. Renmin Hui. I'm Assistant Director General for the Universal Health Coverage, Communicable and Non-Communicable Diseases at the World Health Organization. I'm delighted to introduce this session on global targets, national impact, country 1990 case studies. As you have just heard from Executive Director of UNAIDS, Winnie Byanyima, to achieve the 1990 targets, we will need to work even harder, address inequalities in the deliverable of services, and bring the HIV testing, treatment, and viral load suppression to those left behind. There has been considerable progress in achieving our 1990 targets across continuum of care. We see 79% of 37.9 million people living with HIV/AIDS who know their HIV status. 23 million or 62% on antiretroviral treatment, and 53% with a suppressed viral load at the end of 2018. We will be learning about updated numbers during the AIDS 2020 conference in just a few days. We anticipate that we will continue to make progress. However, we also know that the pace of achievements varies by regions and by country. Some regions has fallen behind, and extra efforts to increase testing, treatment coverage are required to achieve our targets. We cannot end AIDS as a public health threat if we do not invest in prevention first and ensure that all people living with HIV/AIDS, including key populations across all age groups and in all parts of the world, are accessing testing, treatment, and maintaining a suppressed viral load. In order to eliminate HIV as a public health threat, countries will need strong public health interventions, clinical services, community engagement, and program management. We'll hear about how 4 countries are leading the global efforts. Now it's my great pleasure to introduce 4 excellent speakers who will be presenting the progress made towards achieving 1990 targets in their respective countries. Our speakers today come from diverse countries at different stages on the pathway to ending HIV as a public health threat. You will hear first from Dr. Francois Daibis. Dr. Daibis is a medical doctor, professor of epidemiology at the School of Public Health of the University of Bordeaux, France. Since March 2017, he has been serving as Director of France's National AIDS and Viral Hepatitis Research Agency, where he coordinates the Ministry of Health, the public health programs against HIV/AIDS and STIs in the southwestern part of France. He has more than 30 years experience in research on HIV/AIDS epidemiology and global health. Second, you will hear from Dr. Irene Hall. Irene Hall is Deputy Director for Surveillance, Epidemiology, and Laboratory Science Division of HIV Prevention in the National Center for the HIV/AIDS, Viral Hepatitis, STD, and TB Prevention at Centers of Disease Control and Prevention in the United States. She oversees the surveillance, epidemiological, and laboratory research activities in the division. Her research interest has included trends in HIV among gay and bisexual men, impact of HIV on urban and rural community, survival, and indicators of HIV care. Thirdly, Dr. Catherine Ngugi will present. Dr. Ngugi is the head of National AIDS and STIs control programs in the Ministry of Health in Kenya. She is a renowned public health specialist and epidemiologist with a special interest in the children's, adolescents, and young persons in HIV and STI programming. She believes that this war can be won through the concerted effort at the various levels, community having a political goodwill, financial and technical support by all other key stakeholders. And finally, the last speaker in this session is Dr. Hu Tun In O. Dr. O is Country Program Director of National AIDS Programs in Myanmar. He brings to the position more than 20 years experience in clinical and public health field. Currently, he acts as the person of the country HIV technical and strategic group, which is multi-stakeholder group, uniting the members from different constituencies as a key leader, conceptualize the proposal for resource mobilization under different funding resources and multilateral and bilateral development partners. So thank you. I'm looking forward to their wonderful presentation.
Hello, everyone. I am Irene Hall with the U.S. Centers for Disease Control and Prevention. I will be speaking about the progress in the United States towards the 90-90 goals and our goals for the future. In the U.S., the estimated incidence decreased 8% from 2010 to 2018. However, progress has stalled. HIV incidence has been stable after 2013, and we estimated more than 36,000 people were infected with HIV in 2018. In the US, we have been assessing the percentage of diagnosed infections, receipt of care, and viral suppression as part of the national HIV strategy. Our robust surveillance system provides information on the number of people with diagnosed HIV, persons in care, and viral suppression. The percentage of diagnosed infections is obtained using surveillance data and a CD4 depletion model to estimate overall prevalence. Diagnosed infections have increased over time. For 2018, an estimated 86% of infections were diagnosed. Among persons with diagnosed HIV, 76% received at least one care visit based on a reported CD4 viral load test result, and 65% had a suppressed viral load at their last test. For this indicator, the comparable target to 90-90-90 is 80%. However, to substantially reduce HIV incidence, bolder targets, rapid achievement of these targets, and new approaches are needed. In 2019, the US government announced a new HIV initiative to decrease incidence by 75% by 2025 and more than 90% by 2030. Meeting these goals will require rapidly achieving high levels of diagnosed infections and viral suppression, as well as substantially expand use of PrEP and syringe service programs. We also need to expand our capacity to detect and respond to growing clusters of infection. While targets are national or even global, the burden of disease is concentrated by geography and population. Therefore, intervention is local. In the first phase, the initiative is focusing resources on areas where HIV transmission occurs most frequently. Here we see the areas that comprise more than 50% of new diagnoses. That is only 48 counties, Washington, D.C., and San Juan, Puerto Rico. In addition, 7 states with substantial rural burden are included. We must also address disparities to be successful in reducing HIV infections. This slide presents a comparison of the racial distribution of the US population and among persons infected with HIV in 2018. In 2018, Blacks or African Americans made up approximately 12% of the US population, but accounted for 42% of infections. Hispanic Latinos made up 17% of the US population, but accounted for 28% of infections. And whites made up 62% of the population, but accounted for 25% of infections. So the targets apply to all groups, and we need to monitor progress for all groups. This map presents the percentage of diagnosed infections at the end of 2018 by jurisdiction. 9 jurisdictions indicated in the lightest shade had met or are close to meeting the target with a percentage of diagnosed infections of 88% or more. Among persons with undiagnosed infections, Blacks are disproportionately affected, making up 42% of persons with undiagnosed infection. Hispanics are also disproportionately affected. This map presents percentages of persons with virus suppression in 2018 by jurisdiction. The target of 80% virus suppression among persons with diagnosed HIV corresponds to the third part of the 90-90-90, and 2 jurisdictions met that target. 9 states in the lightest shade reached percentages above 74%. We do not have population-based data on the number of persons on ART. However, among persons in care, the viral suppression rate was 85%, and 12 jurisdictions had viral suppression percentages of 90% or more. This graph presents receipt of care and viral suppression by HIV transmission category. In the US, about 60% of persons living with HIV are men with infection attributed to male-to-male sexual contact. Here we see that MSM had the highest percentages of care and viral suppression, while males with infection attributed to heterosexual contact or injection drug use had the lowest care and viral suppression rates. This graph presents receipt of care and viral suppression in 2018 by race ethnicity. The highest percentages of care and viral suppression were among persons of multiple races and whites, followed by Asians. Blacks or African Americans had the lowest percentage of viral suppression. Treatment guidelines call for initiating ART promptly after HIV diagnosis. However, here too we see disparities. This graph presents the percentage of persons with viral suppression within 6 months of diagnosis in 2018 by race ethnicity. Asians had the highest percentage of viral suppression within 6 months of diagnosis, followed by Hispanics, Latinos, persons of multiple races, and whites. The lowest percentages were among Blacks or African Americans and American Indians or Alaska Natives. So while we have made progress towards reaching 90-90-90, the data show we need new approaches to meeting our targets, and relying on testing and viral suppression alone may not have the required impact to substantially reduce HIV incidence. A critical component of the initiative to end HIV in America is PrEP. We're monitoring PrEP coverage, the percentage calculated as the number of persons prescribed PrEP divided by the estimated number of persons who had indications for PrEP. Overall, PrEP coverage was 18% in 2018. The map shows PrEP coverage by area of residence, with PrEP coverage ranging from 5% in Wyoming to 41% in New York. The graph on the right shows PrEP coverage by race ethnicity. PrEP coverage was highest among whites at 42% and low among Hispanics or Latinos and Blacks or African Americans. Finally, we must address the impact of COVID-19 on people with HIV and prevention programs. Interruptions to programs and services have resulted in reduced availability of facility-based testing, disruption to data collection for surveillance, reduced public health services such as partner services, and linking persons who have fallen out of care back into care, and reduced access to PrEP services. To address these challenges, we are monitoring testing and care with alternate data, and promoting testing through self-testing and self-sample collection, which can also be used for PrEP monitoring as those tests can detect recent infection. Further, we are expanding telehealth approaches, and where possible, studies are moving to online data collection. However, interventions are often not able to be moved online. We're also expanding e-learning, skills-based technical training, and remote technical assistance and consultation. In summary, the US is on course to reach the 90-90 goals in the near future. with some jurisdictions having already achieved these goals. However, to reduce HIV incidence by 90% by 2030, the US will need to rapidly meet the new targets, deploy a comprehensive strategy with novel approaches to testing, retaining persons with HIV on treatment, and preventing new infections with PrEP and syringe service programs. And we must address disparities in HIV infection and services. Thank you.
Thank you. My name is Dr. Catherine Ngugi. I am the head of the Division of National AIDS and STI Control Program in Kenya. And I'll be presenting to you the Kenyan 1990 journey, splitting towards 95, 95, 95. I'll start off by giving an overview of Kenya HIV prevalence as per Kenya National Population HIV Impact Assessment Survey that was just concluded in 2018, but we just launched it, a preliminary report, retest, in like 2 months ago. So our prevalence, we are at 4.9%, females at 6.6%, and males 3.1%, with geographic variation of highest burden of 19.6% in Homa Bay County, and lowest burden 0.1% in Garissa County. And you can see through the density of the map on the right of which counties are more affected or which have higher prevalence. But we've come from afar because in 2015 we had, like, for example, Homa Bay County had more than 23%, and now you can see it's at 19.6%. 70% of the infections that we have in the country, we have around 1.2 million people living with HIV, are found within 9 high burden counties, as you can see, concentrated within on the lakeside. And we, in the Kenya strategic framework, which has just ended, was focusing more programming to high and medium burden counties towards epidemic control. That framework, geographic prioritized, was based on where the burden is more highest. And so, but as of 2019, the estimates we had is 42% of the HIV new infections occur among adolescents and young persons. So let me give you a highlight of policy roadmap towards the 1990. In 2015-2016, we released, we gave out guidance on test and treat as per WHO recommendations, and as well caregiver toolkit and adolescent package of care guidelines. In 2017, we released guidance on HTS, HIV testing services and PrEP, and as well as a DST operational guide. And then 2018, we had the ART 2018 guidelines and guidance on viral load and load cutoffs. In 2019, we had we released guidelines on self-testing and on DTG for women of reproductive age, and guidance on phase out of nevirapine and evidence for CAL HPV. This is some of the guidances that we give, but I want to concentrate on more on the one which looks green, which is the one for 2018. The one for 2018 highlighted concentrated on 2 main areas, especially DTG for men, and as well as a cutoff of the viral load. And this guide mostly it was more concentrated on uptake and implementation. So, and as well, it stratified DST based on vulnerability, especially CAGs and fast track for patients and individuals pickups at particular sites. Now, before the 2018 guidance, we had our cutoff was more than 1,000, but now after that, we reviewed it to have more than 400 after 2018, whereby we have LDL up to 399, and then 400 to 999 was more on low levels viremia. And as well, during this time, the viral load, we ensured that for the clients who are starting off on treatment, especially more than 25, during the first year, they had to be monitored on viral load twice, but thereafter it was annual. However, for adolescents and children, it is still biannual. and ensure that the ones who have high viral load, especially as they've given those 2 cutoffs, we ensure that they immediately were called back for review and had short TCAs and enhanced advanced sessions, and had allocated to them assisted treatment budget. And we ensure that we repeated viral load within 3 months. The other guidelines are regarding adolescents and the caregiver training manual, which you have just released lately within the last 2 months, and the differentiated care guideline operation guide. So where are we as a country? And into the ages 0 to 64, you can see we are 79.4 for the first 90, second 90, 95.7, and that 90 around 88.4%. In further disaggregation of this, we are in the ages now 15 to 64, we are at 79.5%, 96%, and 90%. You can see we still have a gap in the first 90, but the second and third 90, at least we have attained for 15 to 64. But in the first 90, we still have a gap in it. But what really has helped us to get here is the various DSD models implemented for adults, as I have highlighted before, to support especially retention in care, and as well adopting TLD as first-line ART for eligible adults. For 0 to 14 is where we are still having a big gap, especially on the first and the third 90, as it is shown there. We are at 78.9% in the first 90, and second 90, 67.1%. So definitely we need here to further disaggregate data by age to appreciate age-specific barriers in care. We need to, if you can see, there's a bit of overlap with the 15 to 64. And so here we are doing further disaggregation to ensure you have 0 to 9 for children, 10 to 19 for adolescents, and 10 to 24 for young persons. Now, what is the role of, what are we doing? What is the role of Ministry of Health, especially in NASCOP, knowing very well that we have health devolved in Kenya? Definitely we play a role of 4 areas: strategic information, special generation of data, encouraging data use for informed decision making, all the way from the facility level, sub-county, county, and the national level, conducting research to ensure we see what is working and what is not working, and documentation of innovation dissemination for scale-up, as well as coordination, establishment of regional TWGs. We have around 8 of them in the country, and as well at the county level, and the committee of experts, and engagement and collaboration with stakeholders such as people living with HIV, networks, and as well CSOs, county governments, donors, and other relevant ministries and development partners. As well, we do technical oversight, where we ensure that we do supportive supervision and mentorship. We conduct trainings and capacity build sessions. Especially right now, we are doing a lot of virtual, but before we used to do physical ones. Socialization of stakeholders and the community health management team, and continuous on-job education, initiating pilots or innovations. And finally, in standards and guidance, developing and disseminating new standards and guidance, and monitoring adherence to the guidance, and ensuring that we share good practices. What has worked for us to see, especially on the where we are right now? The first 90, especially what has worked for us, integration of HIV testing within all service delivery points, and as well as provider-initiated testing and counseling, and assisted partner notification services has helped us to identify, because that one is more targeted. And then in the second 90 test and treat guidelines, and the guidelines as I've highlighted, especially for 2018 on TLD rollout, and as well as viral load cut of new guidance was very good. And guidance on optimized regimens is supported by WHO, and implementation of DSD models and peer supports to vulnerable patients. So what are the priority areas currently is more in the first 90 for us to where we are, as I've said, we want to sprint to 95. And what we want to do in the first 90 is to have targeted and differentiated HIV testing, scale up of impactful approaches, especially self-testing and index testing strategies, as well ensuring that we address any contentious issues that we have had in the country. The second 90 definitely is, that 90 now is to ensure that we have optimal ART formulations for CAL HIV, and looking forward to having 5 milligrams and 10 milligrams of BTG, so as it can help us to be able to reach to the other children we are not able to reach to. An expansion of DSD models to address needs of children, strengthen peer-led approaches, and strengthen HIV literacy among caregivers of CAL HIV, and support engagement, support a private sector engagement of DSD. And overarching is definitely guideline review to adopt WHO recommendations and strengthen multi-sectoral collaboration, and as well human-centered design for implementation, and finally address age and gender-related barriers. In all these, we know that definitely we would not have done it without the county government and without the the donor agencies and implementing partners that we have in the country, and as well as the leadership of the ministry with different ministries of education and Minister of Health has really played a very big role for us to ensure that we achieve where we are right now. And we hope, especially where we have the gaps, we can be able to address them within the recent, the few months that we have, and ensure that we catch up to them. But for my interest more is the CAL HIV. And we hope because of the optimal arrangements that we have given to the CAL HIV, we hope by uptake by the end of the year will be more than 95%. Thank you.
So today, I'm going to present Myanmar on the path to 1990 and beyond. I'm Untitled, Director of the National AIDS Program from Myanmar. So this is my presentation outline. We include the country profile, Myanmar HIV epidemic at a glance, key strategy used by the country, progress and way forward. So Myanmar is one of the countries located in Southeast Asia region with the area of the 676,000 square kilometer, and it has a population of the 54.4 million. Two-thirds of the population stay in remote rural area of the country. And it has administratively, Myanmar has 7 states, 7 regions, and 1 union territory. So this slide shows the Myanmar HIV epidemic at a glance. The first HIV case was detected in 1988. Its first case was confirmed in 1991. Myanmar has 240,000 estimated population. It has the HIV prevalence of 0.5%. The epidemic is concentrated among the key population with the higher risk, including people who inject drugs, men who have sex with men, and female sex workers. The population site estimate of the PUID is 93,000. That of MSN is 126,000, and female sex worker is 66,000. HIV prevalence among the MSM and female sex worker was declining slowly over the past few years. However, the progress is much more modest among the people who inject drugs. The prevalence among these PUID is slightly increasing from 23.1% to 34.9% in the most recent IMDs. So this slide shows the estimated new HIV infection by population segments in Myanmar from 1990 to 2020. At national level, the HIV epidemic appears to be declining. However, the epidemic at subnational level is quite different from region to region. The subnational estimates show the size of pockets of increasing incidence in high-burden state and region, especially PUID in Kachin state and MSN and in the Yangon region. So Myanmar is responding HIV epidemic with the 5-year national strategic plan and its operational plan. National strategic plan guide for the country respond to HIV at national and subnational level. Currently, Myanmar is implementing HIV actively as per the third national strategic plan 2016 to 2020. In terms of the setting the target, Myanmar set the 5 strategic milestones for 2016 to 2020 that covering the prevention, testing, treatment, and the fifth 90 is reducing the discrimination among the people living with and affected by HIV. Over the next 5 years, so Myanmar will move from 90 to 95 strategic milestones, with the exception of the fifth 90, because discrimination against people living with HIV is unacceptable in all settings. So that is why that we will move from the 90% to the 100% in the over the next 5 years. This slide shows the key strategies in the recent year. Myanmar prioritized the geographic prioritization based on the HIV burden, differentiating service delivery, putting out the services across the cascade, adopting the innovative approaches and moving the electronic-based information system. In addition, Myanmar officially joined the Global HIV Prevention Coalition in last May 2018. In terms of the seeking HIV testing by the target population between 2011 to 2019. So here we can see the increased coverage among the testing coverage among the key population, other vulnerable population over the past 5 years. These other vulnerable population include institutionalized population, uniform service personnel, migrant worker, new TB patient, blood donor, young people under 15, and other low-risk groups. Myanmar also practice hand reduction and methadone maintenance therapy. The MMT program was started in the last 2006. Now, as of the December 2019, nearly 20,000 clients are receiving MMT in 71 MMT sites across the 5 high-priority region states. Among them, 50 sites practice the one-stop shop services. Progress toward the second 19th from 2005 to 2019. Obviously, Myanmar could make tremendous scaling up of the ART in last 5 years. So as of the December 2019, 184,000 PLHMB are receiving life-saving treatment. That is 77% of all people living with HIV in the country. So this slide shows the progress toward the 90 targets over the past 5 years. Here we can see Myanmar is on track of last to 90 and almost on track to the first 19 in recent years. In terms of the legal environment, so new HIV laws was drafted and announced in government newspapers for wider public comment. Myanmar also developed sex worker law. It was discussed and revised in Parliament Legal Affairs Commission. And Myanmar also amended 1993 Narcotic Drugs and Psychotropic Substance Law in last February 2018. Myanmar also developed National Drug Control Policy in collaboration with the other related ministry and stakeholders. This slide shows the key operational model to be implemented in the next 5 years. So in terms of the geographical prioritization, so Myanmar will prioritize 167 townships out of the 300 townships in country. So we integrate the essential and comprehensive HIV service set to universal health coverage in all 167 townships. And we also integration of the service and we create the accessibility and the cost efficiency. In the map, you can see the blue color highlighted area are the high priority township in all region states. Another essential package of the health services that is implemented in the all 330 townships include basic HIV prevention, facility-based testing, care and treatment of ART, PNTCT, integration with the other services like the TB and related community distribution and community center approaches, normalization of HIV in healthcare and community setting. Another comprehensive package of health services that we implement in high priority townships. So include, in addition to the essential packages, so we include the combination HIV prevention, HIV testing facility and the community-based self-testing and care and treatment. So integrated with the other services like mental health, hepatitis C, sexual and gender-based violence services for ADS user and non-communicable diseases. And community distribution will include the PrEP and WAVE pilot, buprenorphine in addition to the MMT, and sensitization training on reducing stigma, keyboard-friendly services, etc. This slide shows the historical and projected national aid spending from 2012 to 2020. I think last 2017, so Myanmar is contributing 20% of the all national aid spending in country. The support from the government of Myanmar cover 100% of the methadone and more than 80% of the antiretroviral therapy procurement. So under the NSP4, sustainable financing option to increase the domestic funding base will be demonstrated. These include development of the resource mobilizing strategies, innovative funding models such as social contracting and partnership with the private sector. This is my last slide, way forward of the country. So based on the achievements and lessons learned, the current phase of the AIDS response in Myanmar is integrated into the Sustainable Development Goal agenda. So Myanmar will enhance HIV combination prevention and testing services, promote awareness raising, tax shifting initiative wherever possible. Myanmar will improve the linkage to care and find a way to minimize delayed treatment seeking among the population. And we try to assess integrated co-location with the co-morbidity and co-infection. And we provide the greater effort to address stigma and discrimination in community and within healthcare services across the every level. So we expand multi-stakeholder partnership with policymaker, parliamentarian, ethnic health organization, and private sector. We promote community-led services, empower community-based organization and self-help group, etc. So that is the end of my presentation. Thank you for your kind